So, good evening, everyone. We'll continue our series on one lecture every week, every Saturday. And we have started a new series on antifungals now. We have completed terbinafine last week, and this week we'll continue this series with itraconazole in dermatology. Terbinafine and itraconazole are one of the most common antifungals that we use for treating dermatophyte infections. And that's why I thought that we'll shift the class from allylamines to azoles now. And this week, we'll start with the series on azoles antifungals in dermatology. With the first azole that we'll discuss is itraconazole in dermatology, and this would be a bit more detailed video, and you will realize that this video has everything which you would require to know about itraconazole, especially if you want to answer your vivas, especially if you want to know how to treat, when to treat, what all dosages to start with if you're using itraconazole to treat your patients of fungal infections, what all things to keep in mind when you're using itraconazole for treating your patients. So we'll sequentially go through these drug study of itraconazole, and we'll start like always from introduction and go through the pharmacology, the mechanism of action, the side effects of itraconazole, the uses, and some few salient extra points about super bioavailability available itraconazole and the use of itraconazole with antacids and other acid lowering agents. So we'll discuss that in brief in the end, and trust me, at the end of this video you'll be able to easily use itraconazole, and you will use it more judiciously and more carefully. So without further much ado, let's start with our video on itraconazole in dermatology. Now itraconazole is a first generation triazole. It's a first generation triazole, and what we mean by that? Well, antifungals can be divided into either allylamines, okay, allylamines, or they can be divided into azoles, or they can be divided into echinocandins, and there are other classes also, capsifungins and all, but majorly are uh, we usually deal with allylamines and azoles, and allylamines include terbinafine, which we discussed last week. Azoles can be divided into two classes. We have imidazole, and we have triazole, and it depends that how many what is the number of nitrogen atoms in the ring that is there in the chemical structure. So terbinafine and itraconazole both have a ring structure at one end, and depending on the number of nitrogen atoms, you divide them into imidazole and triazoles. Okay, so this is the itraconazole is the first generation triazole, but you can say that it is a second generation azole. So let me just clear everything out so that we can make much more sense. Good enough. Okay, so azoles, you have first, second, and third generation. First generation includes azoles like ketoconazole, okay, or fluconazole. These kind of imidazoles basically. Not fluconazole, but ketoconazole. First generation azole is ketoconazole. Second generation azole is itraconazole, fluconazoles, these kind of drugs. Third generation azole are isavuconazole and posaconazole, voriconazole, these kind of azoles. We will not be discussing this third generation in this series of antifungals because we are discussing majorly the the drugs which are used to treat superficial fungal infections. But if you want me to go deeper into the deeper mycosis, systemic mycosis, covering fungus like aspergillosis, basidiomycosis, and all that, then we can make a separate video on this. But right now, our focus on discussion is more on using itraconazole in superficial mycosis or skin mycosis. Okay. Now coming back to itraconazole. Itraconazole is a racemic mixture of two enantiomeric pairs. You need not remember that. Just remember that itraconazole is a mixture of different kind of racemeric products. It got approval to be used in systemic mycosis in the year 1992 and for onychomycosis in the year 1995. And additionally, the pulse therapy of itraconazole got approval to be used in onychomycosis in 1997. Okay. It's available as capsules in the form of 100 mg, 200 mg, in solution form in the form of 10 mg per ml, and even as a topical gel 1%. Other formulations are also available. For example, 0.7% gel was used in some of the studies, but majorly it is available as a 1% gel. The IV form was also there initially, but now it has been discontinued. It has been stopped. So we have itraconazole as an oral preparation only, and it comes as a capsule, as tablet, or even sugar coated spheres. So whenever you have access to a itraconazole capsule, I request you to open the capsule and see what is inside. What we have are little white pellets or little white spheres or little balls which are coated with the drug of which are coated with itraconazole. So you have a sugar pellet, then you have a coating of itraconazole drug, and then you have a sealing coating which seals the drug so that it doesn't get dissolved or doesn't get destroyed by the stomach acid. We'll discuss that in little bit more detail when we'll be discussing the pellet structure of itraconazole. Okay, so Wolverton mentions that absorption of it. Wait, just a second. Yeah, absorption of itraconazole happens after if you take it with food after a fasted state. So best is to take it with breakfast early in the morning. It also mentions that the absorption is increased with cola if you take it with a cola beverage, and there have been studies which compared absorption when half of the patients were taking it with cola, half of them were taking without cola, and it was found that higher levels were achieved when you take itraconazole with cola. That's what Wolverton mentions. But the point that has to be stressed upon is that it has to be taken with food but after a fasted state. Okay. The oral suspension can be taken without food, with food. It won't matter much. The suspension has cyclodextrin inside, which helps in proper dissolution of itraconazole in the intestine and good absorption. So remember, whenever you counsel your patients on when to take itraconazole, take it early in the morning with breakfast. That will do. Okay. Itraconazole undergoes significant hepatic metabolism in the liver via the enzyme CYP3A4. And after the metabolism, it gets converted into hydroxyitraconazole. And hydroxyitraconazole is also having some kind of antifungal action. So itraconazole and hydroxyitraconazole both have antifungal action. Okay, so both of the metabolites, that is why it is known as active metabolite. The metabolite also has the same action as the parent drug. Peak levels are achieved in 3 to 5 hours. The bioavailability is 55%. This is from the drug insert, that the bioavailability of itraconazole is 55%, while the granules are 36 to 64% bioavailability. Okay, it is 99.8% protein bound, plasma protein bound, and the half-life is 21 hours. If you want to go for a range, it is 37 to 40 hours, but averagely it is said to be having a half-life of 21 hours. 40% of the drug is excreted in urine, and most of them is either in the itraconazole form, unchanged, and hydroxyitraconazole form, which is the active metabolite. And it has been found that the level of excretion in urine is actually low that we expect. The reason being that itraconazole specifically and preferentially binds to keratin structures. So most of the drug is stored into the skin, the hair, nails, and all those keratin structures. That is why it is available less in the system. And a drug that has such a high protein binding of 99.8, the amount of drug which is freely available in the blood is less. So you have decreased amount of secretion into the urine. So we told you that itraconazole undergoes significant hepatic metabolism. That means if liver is damaged, the half-life can increase as much as 2 times. So if liver is damaged, the half-life can actually become double. Other thing to remember is that Wolverton mentions that the amount of cola that you have to take is 8 ounces. And assuming it to be fluid ounces, it roughly translates to 240 to 250 ml of cola, which is roughly 1 glass. But remember, having itraconazole with cola, not every patient might be able to have it. What I usually tell them is to take with little bit of lime water. That helps. But otherwise, we just have to say that they can take it once with breakfast, because that is that's a good intake of food after a fasted state. That's what the textbooks mention. Okay, so let's move forward. Now, how does itraconazole act? So this is the same diagram that we showed in the terbinafine video. but this time we'll be discussing the azoles group. So azole group act on the cytoplasm of the fungal cell. And why does it, what actually it does to the cytoplasm is that it inhibits the synthesis of ergosterol. Remember that terbinafine was doing the same thing by inhibiting the squalene epoxidase enzyme, and when that enzyme is inhibited, the amount of ergosterol formed is less, and when ergosterol is less, it is not the fungus is not able to create its own proper cell membrane, and thus the fungus is not able to grow properly, leading to fungistatic action of terbinafine. That's what was happening with terbinafine. While in azole, the end result is that ergosterol is not made properly, and the cell membrane is not able to allow the growth of fungus. And that is how azoles have a majorly fungistatic action, but in high doses, it can have a fungicidal action also because of accumulation of previous byproducts. So in terbinafine, we saw that the accumulation of lanosterol leads to some kind of increased permeability from cell membrane. That is why leading to fungicidal action of terbinafine. A similar kind of story plays well with azoles, that the major action is because of inhibition of synthesis of ergosterol, and now they would like to now the accumulation of all the previous metabolites is now leading to a fungicidal action. Okay, but remember the major action of itraconazole is fungistatic in the routine doses, fungicidal maybe in the higher doses. Okay. So when we take itraconazole, it reaches skin by passive diffusion from plasma to keratinocytes. Sorry. So it goes to the skin from the plasma by a passive diffusion, and it is strongly keratophilic. That means it likes keratin very much. And that is the reason why it gets adhered to the keratin. So here let's say we have keratin cells, we have keratinocytes, and we have blood vessels. So when itraconazole comes inside the blood vessel, it will diffuse out passively into the cells, the keratinocytes, and because it being highly keratophilic, it gets accumulated inside the cell and stays there by attaching itself to keratin, and that is how majority of the drug after intake stays at the level of action, the site of action. Now it is detected within 24 hours in sweat. But even despite this early detection in sweat, the excretion of itraconazole is very minimal. Okay, other drugs like griseofulvin, ketoconazole, fluconazole show significant excretion through sweat. We'll discuss that in detail when we'll be discussing the individual drugs. But as far as itraconazole is concerned, the excretion through sweat is minimal. Itraconazole is extensively excreted into the sebum. Okay, so sebum's secretion is also increased with itraconazole. It remains in skin for 3 to 4 weeks after discontinuation. So when you stop drug, it remains in skin because it being a very strongly keratophilic, it remains in skin and it stays there for the next 3 to 4 weeks. Itraconazole is eliminated with hair, nail and skin growth. Increased shedding of keratinocyte is actually the way the itraconazole leaves the system. And it has been said that when itraconazole gets accumulated in the skin, when itraconazole systemically is stopped, it diffuses back from skin into the circulation. Okay, so that also happens. When you give itraconazole for onychomycosis, it reaches the distal end of the nail. So let's say this is the nail plate. So it goes from the blood vessel into nail matrix into the nail bed, and here it passively diffuses into the nail plate and it reaches the distal point of the nail plate in 1 week if it is the fingernail, and 2 weeks if we are talking about toenails. Okay, and the diffusion is towards from the matrix. So let's say this is the nail plate, and this is the matrix. This is the cross section, vertical cross section of a finger or a toe. And if the area below the nail plate is the nail bed, itraconazole diffuses from the nail bed and the nail matrix. Okay. If you give itraconazole as a pulse therapy for onychomycosis, it readily leads to levels which are more than MIC for the fungus. That means it helps to reach the effective fungal concentration, antifungal concentration. When you stop itraconazole, it becomes undetectable in fingernails in about 9 months after stopping, and in about 11 months in toenails. The reason why it takes longer time in toenails is because toenails actually grow slower as compared to fingernails. Okay, and plasma levels are negligible in 1 to 2 weeks after stopping. So if you stop, plasma levels will go negligible in 1 to 2 weeks, while it will take 9 months or 11 months to go out from nail. That's why it becomes a very good drug when you're treating onychomycosis. Okay. When treating fungal infections of hair and you're using itraconazole, there are two basic routes by which itraconazole reaches hair. One is sebum and other is incorporation into hair follicle. So if you have, let's say this is the hair and a inside a hair follicle, and this is the pilosebaceous unit or the pilosebaceous glands. We told you that itraconazole gets a lot amount of itraconazole is excreted via sebum. So because of that, sebum becomes one of the major routes by how itraconazole reaches a hair follicle. And when hair is dividing, hair also has keratin. And itraconazole being a very good keratin liking agent or a keratophilic agent, it gets incorporated as the hair grows. Okay, so that's how itraconazole reaches hair follicles. It is detectable after 1 week of therapy, and if you give pulse therapy, then after second pulse, the concentration is about 2 to 3 times higher than starting. So first pulse, it won't lead to much accumulation, while from second and third pulse, you will see 2 to 3 times the concentration, and it stays roughly about 9 months after discontinuation. So for fingernail, it is 9 months. For toenail, it is 11 months. For hair, it is also 9 months. Okay. So that is why the pulses which are recommended are 2 pulses for finger or 3 pulses for toenail onychomycosis. Okay, so now we have learned about the basic. We have learned about the basic pharmacology of itraconazole. How much time does it take to reach skin, nails, hair? Why it stays there, and how much time will it spend there after stopping out drug? And so we have certain idea about what itraconazole actually does when it reaches the fungal colonies or the fungal deposition, when it reaches the area where it's supposed to act. Now, how does it help to stop the growth of fungus? Now we are going to study about the mechanism of action of itraconazole. Now it inhibits the enzyme lenosterol 14 alpha demethylase. It's a very important enzyme in the formation of ergosterol. We'll discuss that in the next slide. And lenosterol 14 alpha demethylase is supposed to demethylate or remove the methyl group from lenosterol and further carry on the conversion till ergosterol. Okay, so you have lenosterol, and after lenosterol alpha 14 alpha demethylase, after many steps you get ergosterol. Okay, when this enzyme is inhibited by itraconazole, these steps don't happen, and you have accumulation of lenosterol and decrease ergosterol. And ergosterol is an important compound for fungal cell membrane, and that is why you're supposed to have a good amount of ergosterol for the fungus to grow. When fungus doesn't get good amount of ergosterol because of inhibition by itraconazole, it stops growing, and that is how the fungistatic effect of itraconazole happens. Okay. Okay, so in the previous slides we have discussed very briefly about the mechanism of action of itraconazole, and this is the same diagram that I had discussed last week when we were talking about terbinafine. So this is the mechanism of action of formation of ergosterol. Now ergosterol is very important for fungal cell membrane synthesis and fungal cell replication. It starts from the acetate, from the molecule acetate, and after subsequent steps it forms squalene. And squalene, under the action of squalene epoxidase, and after multiple steps forms the molecule lenosterol. Okay. Now this squalene epoxidase is inhibited by terbinafine. It is inhibited by terbinafine. And what happens is that this time the inhibition will happen at the level of lenosterol 14 alpha demethylase. Now 14 alpha demethylase, what happens is that it has a certain heme moiety, the same heme molecule that we have in hemoglobin. So that heme moiety is blocked by itraconazole, and because of itraconazole, that heme moiety is not able to attach itself with the oxygen molecule and is not able to properly carry out its function. So the 14-alpha demethylase enzyme is not able to function properly, and there is no conversion from lenosterol to 14-alpha demethylenosterol. So this compound actually decreases. When this decreases, this leads to further decrease in ergosterol. Okay, so triazoles like fluconazole and itraconazole and imidazoles like ketoconazole inhibit 14-alpha demethylase, leading to accumulation of lenosterol and decrease in ergosterol. This decrease in ergosterol is then not able to implement or get incorporated in the fungal cell membrane, leading to leading to fungistatic effect of itraconazole on the fungal cell membrane, and that is how itraconazole stops the growth of fungus. Am I clear on that? And after that, there has been reports that increased lenosterol can either lead to the fungicidal action of itraconazole when higher doses are used. But remember that the major action of itraconazole is fungistatic in nature, and that is because of deficiency of ergosterol. Okay, and the cell membrane is not formed. Am I clear on that? So lenosterol increases, ergosterol decreases, and because of the deficiency of an important molecule like ergosterol, the fungal element is not able to grow properly. Now, F14-alpha demethylase comes from a family of cytochrome enzymes, which is CYP51, and thus it's a cytochrome P450 dependent enzyme, and because itraconazole acts by inhibiting cytochrome P51, it can also have additional action on cytochrome P450, and that is where all the drug-drug interaction comes for the azoles. If you look at the product insert of a specific azole, let us say itraconazole specifically, and you will see a huge list, a very long list of drug-drug interactions, and that is because of the action of itraconazole on cytochrome P450 enzymes. So this becomes a very important aspect to understand and take a good drug history when we are actually treating our patients with itraconazole. Clear? Let's move forward. So we have understood how itraconazole acts and where itraconazole acts. We'll discuss the uses of itraconazole. So it has been approved by FDA to be used in onychomycosis or tinea. We have discussed about the difference between these two in the previous video. The dose that is recommended is 200 mg once a day for 12 weeks if you are treating toenail. If you are treating fungal nail, the pulse regimen is recommended. It has lesser side effects and much more compliance in the pulse regimen. Okay. Now remember that oral medication and the solution medication are interchangeable. You can interchange them. Just remember that solution has greater bioavailability, so you need to decrease the dose. This is roughly 5 mg per kg per day, 5 mg per kg per day. This is approximately 3 mg per kg per day. A lower dose is required. We'll discuss that in future slides when we'll be discussing the use in pediatric population. Other dermatosis in which it is FDA approved is oropharyngeal candidiasis, where the solution one is preferred. Esophageal candidiasis, where the solution one is again preferred. And systemic mycosis like blastomycosis, histoplasmosis, aspergillosis. Okay, this kind of deeper systemic fungal infections, we can use itraconazole, especially if these systemic mycosis are resistant or not showing adequate response with amphotericin B. Okay, so if it's not showing good response with amphotericin B, the second line drug is itraconazole. Okay. Okay. So these are the FDA approved indications. In systemic mycosis, you may require IV itraconazole. It is not available, but it's a good idea to use a solution or an oral form. Okay, let's move forward. So discussing the use of itraconazole in onychomycosis, you always think about using continuous or pulse regimen. Pulse regimen is found to be significantly better tolerated, good compliance, less side effects, easy to understand by the patient, easy to take because you don't have to take drug every day, you have to take it only for a week. We have discussed these important definitions in last week: mycological cure, effective treatment, and clinical cure. Mycological cure means negative KOH with negative culture. Effective treatment means mycological cure with 0% nail involvement or more than 5 mm of new unaffected nail growth. While clinical cure means 0% nail involvement. So let's say you have a nail, okay, and you have the whole nail involved with onychomycosis or involved with fungal infection. So mycological cure is if you take KOH or if you take culture, then these both are negative. Both are negative. That is mycological cure. That means you have cured the fungus. Clear? But if you have mycological cure, that means KOH in culture negative and more than 5% of new nail is visible. So that is known as effective treatment. Clear? And if there is no nail involvement, the nail is completely fine, it becomes clinical cure. And various studies are which usually take into account mycological cure and clinical cure says that 44% of patients have mycological cure, while 26% of patients have clinical cure with continuous itraconazole therapy. Other data says that this mycological cure can be as high as 59%, while clinical cure can be as high as 70% when you are using continuous itraconazole. But as I said, for onychomycosis, the pulse form is supposed to be much more effective, and the range is roughly about 63% to 70%. So what do we understand by looking at this data? It means that even if you use pulse form or continuous form, the efficacy is not much hampered by the pulse form. So it's better to use pulse form because it has other advantages of being easy to understand and better compliant. Okay, very better compliance for the patient. So whenever you're treating onychomycosis, because I personally feel that I personally use itraconazole. I prefer itraconazole when I'm treating onychomycosis, and I use the pulse regimen. Okay, I use pulse therapy. So in the last slide, we were discussing about the pulse therapy of onychomycosis when we are using itraconazole. So let's discuss a little bit about what exactly do we mean by pulse therapy of itraconazole. Now it is used for the treatment of onychomycosis, that means the fungal infection of the nail, and the dosages which are recommended is 200 milligram 2 times a day for 1 week and a 3 weeks gap. This forms one cycle. This is one cycle. If you are treating onychomycosis of the fingernail, you have to use 2 such cycles, and if you are treating onychomycosis of toenails, you use 3 such cycles. So the way I explain to my patient is that you have to take the capsules for 2 times a day. You take it for 7 days, and this becomes 1 week. Okay. After taking for 1 week, you skip for the next 3 weeks, and this becomes one cycle. Okay, so you have to give 2 cycles or 2 such cycles or 2 monthly treatment if you're treating fingernail onychomycosis, and if you're treating toenail, you have to increase it to 3 months. We are clear on that? This is essentially the pulse therapy of itraconazole usage in onychomycosis. When we are dealing with pediatric population, children population, we have to use the regimen 5 mg per kg per day for a week. That becomes 1 week. Then you skip for the next 3 weeks. That is one cycle. And that is if you are treating about fingernail, you give it for 2 cycles. If it's toenail, you give it for 3 cycles. Clear? So in pediatric population, you use 5 mg per kg per day, and there are the dosages differ depending on the weight of the patient. If it is from 10 to 20 kg, you use 50 milligram every other day. If it is 20 to 30 kg, you give 100 milligram every day. If it is from 30 to 40 kg, you alternate between 100 milligram and 200 milligram every other day. Okay, you give 100 milligram, next day you give 200, subsequently like that. If it is 40 to 50 kg, it is 200 milligram every day. If it is more than 50 kg, you give 200 milligram twice a day for a week, which is the adult dose. This is same as adult dose. So the dose regimen which we have described for itraconazole pulse is same for adults and pediatric population weighing more than 50 kg. We are clear on that? Now we have understood a bit about onychomycosis treatment with itraconazole pulse, and that is what we mean by the pulse regimen of itraconazole. Clear? Let's move forward. For Tinea Capitis, you have two mechanisms. Either you give continuous or pulse. For continuous, you give 5 mg per kg per day for 4 to 8 weeks, depending on how the child responds or how the patient responds. For pulse regimen, you give 5 mg per kg per day, which is the oral tablets or oral capsules that we are talking about. You give it for 1 week every month for 2 to 4 months. So technically, it is asking you to continue the cycle of onychomycosis, but give it for 2 to 4 months in case of Tinea Capitis, depending on the clinical response of the patient. If you use an oral solution, you shift to 3 mg per kg per day, because oral solution has a good stabilizing agent in the form of cyclodextrin. Clear? So it is much more stable, much more bioavailable, so you can use a lower dose. In Tinea Corporis, Cruris and Pedis, the dose is 200 mg once a day for 1 week or 200 mg once a day for 2 weeks, depending upon clinical response. That means you can increase the doses or the duration of the treatment by 1 more week. But trust me, I don't see patients responding to itraconazole in 2 weeks. You might have to extend the duration to a lot more weeks because of arising resistance and because there is a huge variability between the bioavailability and the efficacy of individual itraconazole brands. Okay, so that's a different problem altogether. For Tinea pedis, it is either 100 mg once a day for 4 weeks or 400 mg once a day for 1 week. Okay, 100 every day for 4 weeks or 400 every day for 1 week. You can also give 200 mg once a day for 2 to 4 weeks. So these kind of variability is present. We can decide any of them to be given in patients of Tinea pedis. Okay, so in the last slide, we discussed about the use of itraconazole in skin fungal infection, dermatophyte infection. We'll discuss a little bit about its use in seborrheic dermatitis. Personally, I use it very rarely in recalcitrant seborrheic dermatitis not responding to the conventional therapies. Now, many of dermatologists believe that seborrheic dermatitis or repeated activation of seborrheic dermatitis or an increased intensity of seborrheic dermatitis is because of repeated activation by the commensal fungi Malassezia furfur. And we know that pityriasis versicolor, the disease caused by Malassezia furfur, responds to itraconazole. Okay, so we can give itraconazole to bring down the effects of Malassezia furfur and thereby reducing the intensity of seborrheic dermatitis if it is triggered by the fungus. The dose that is recommended is 200 mg once a day for a week. You give it for just a week, and if it is recurrent, you can maintain the patient on a prophylaxis of 400 mg once a month for 6 months. I'm clear on that. You give 200 mg once a day for 1 week, and then you maintain on 400 mg a month for the next 6 months to treat seborrheic dermatitis. There have been good studies. The reference is given below. I will also copy paste the reference in the description. I request you all to go and access the full text article and read the whole article, and you will realize the efficacy of itraconazole in seborrheic dermatitis. It has been found to significantly decrease the SDASI scores or seborrheic dermatitis area severity index scores. Significant decrease in itching and significant decrease in burning sensation have also been seen. And there is also a good improvement in the overall subjective assessment of the disease. Clear? So itraconazole is helpful in seborrheic dermatitis. So much so that 1/3 of the patients on itraconazole have nearly complete clearance as compared to placebo. So it is that much significant after 1 week of therapy. So let me just remove these markers. Yeah, so this graph I've taken from the article mentioned in the reference, and it shows that there is significant decrease at the level of 2 weeks of follow-up when itraconazole, this is itraconazole, compared with placebo. So when you give itraconazole 200 mg once a day for a week, there is significant decrease in the SDASI scores. Okay, and we can see that the decrease is seen in placebo also, but the decrease with itraconazole is much higher. So this graph clearly shows the efficacy of itraconazole in treating seborrheic dermatitis. Okay, so remember that seborrheic dermatitis can be treated with itraconazole if it is getting aggravated by malassezia furfur, or is it having a certain amount of recalcitrant or recurring nature. Clear on that? Let's move forward and we'll see the action of itraconazole on non-dermatophytes. Coming to non-dermatophyte action of itraconazole, it has been shown to act against Aspergillus fumigatus, Candidal onychomycosis. There are two fungus also mentioned, which are Scopulariopsis brevicollis and Fusarium species. But many of the articles and textbooks now mention that the action is not good. Action of itraconazole not good. That means it is not effective against these two species. So it's a good idea if if you're telling your examiners about the action of itraconazole on non-dermatophytic fungi, you mention the names of Aspergillus fumigatus, Candida onychomycosis, and we are talking about skin infections. If we go to deeper mycosis, we can easily mention blastomycosis or histoplasmosis. Histoplasmosis, itraconazole is actually the second line drug as per the ITSA guidelines, and other itraconazole is also not effective against zygomycosis actually, if I'm correct, if I'm not mistaken, it is also not effective against zygomycosis. Okay, so let's move forward. Off-label uses include Majochi's granulomas, HIV-associated eosinophilic folliculitis, Tinea imbricata. Now, Tinea imbricata, just a little bit of segue, it is also known as Cascado. Okay, Cascado infection. It is after some island's name. I'm not easily remembering right now, but that's what Cascado is. It is caused by Trichophyton concentricum. Trichophyton concentricum, and you have fungal growth in multiple concentric layers, and it is known as Tinea imbricata. Okay. Additionally, there is an entity known as Tinea pseudo-imbricata, which is caused by Trichophyton rubrum and Trichophyton mentagrophytes, which are the general organism for tinea. But it happens when a patient repeatedly applies steroidal creams on the area, leading to repeated bouts, repeated periods of growth, which has somewhat of a similar appearance, somewhat, not as extensive as Tinea imbricata, but somewhat of a similar appearance as imbricata. That is why it is known as Tinea pseudo-imbricata. Now, if you know one another name of Tinea pseudo-imbricata, mention that in the comments. Otherwise, I'll mention that in subsequent videos. What is the other name for Tinea pseudo-imbricata? Other off-label uses include vaginal candidiasis, chronic mucocutaneous candidiasis, cutaneous porotrichosis, and other Candida albicans infections. Now, coming to off-label uses, when I was researching about itraconazole, I found this good article, which is itraconazole in treatment of non-fungal cutaneous diseases. That means diseases which are not mediated by a fungal infection. And I would request each one of you to go to this article, read it. It's a very interesting article which documents the use of itraconazole in disorders in dermatosis which are not fungal in origin. So it has anti-malignancy action by acting on the anti-Hedgehog signaling pathway. And if you remember your pathology or your dermatopathology, anti-Hedgehog signaling pathway is important for BCC, basal cell carcinoma. So oral itraconazole is found to be effective in basal cell carcinoma. It also has anti-angiogenesis effect, which is used in infantile hemangioma or keloid formation. It has anti-inflammation and immunomodulatory effect, which leads to suppression of T lymphocyte proliferation. Okay, so because of a suppression of T lymphocyte proliferation, itraconazole is used in mycosis fungoides. Okay, and because of this immunosuppressive effect, it has also been documented to be used in lichen planus, HIV-associated eosinophilic folliculitis. We've already said sarcoidosis. Okay, so these are all the other off-label uses, non-fungal uses of itraconazole. It might become a very good viva question. Non-fungal uses of itraconazole, and seborrheic dermatitis is not an answer. We are treating malassezia furfur in that. Clear, isn't it? Okay. Other disorders also include inhibition of neutrophil chemotaxis, so you use it in palmoplantar pustulosis. In fact, the articles mention that within 2 weeks you have complete clearance of all pustule, complete clearance. Okay. Induction of nail growth in disorders like yellow nail syndrome and reduction of hypersensitivity reaction to malassezia fur in head and neck dermatosis or irritation because of application of calcipotriol. So I request you to go and read this article in full. You will understand a lot of non-fungal uses of itraconazole. Okay, so now what we have learned about the pharmacology, we have learned about the mechanism of action, we have learned about uses in fungal disease, in non-fungal diseases very quickly. Post this slide, we'll go very fast, we'll just discuss the important side effects of itraconazole. Now remember that itraconazole shows cross reaction present among azoles. What do we mean by that? That means if a person is having side effects to itraconazole, they might have similar side effects with fluconazole also. Okay, or with ketoconazole also. So the overlapping side effects between different azole drugs show some kind of cross reactivity. So we should keep that in mind. Other side effects include nausea, which is one of the most common side effects seen in about 11% of patients, diarrhea, headache, which means basically GI disturbances, and that is one of the most common side effects. Other issues like cardiac issues, for example, it can cause arrhythmias. It cannot be used in congestive heart failure or in patients with ventricular dysfunction. Why? Because number one, itraconazole decreases cardiac contractility. Also, it has a negative inotropic function. So decrease in cardiac contractility and negative inotropic function you cannot use, or you have to use it very carefully in patients who have history of arrhythmias, or who have other risk factors for congestive heart failure, or who have propensity to develop ventricular dysfunction. Okay, this is very important adverse event. Other important adverse event is hepatotoxicity. Okay, that means itraconazole is a hepatotoxic drug. It also undergoes a lot of liver metabolism, so we need to be careful in that. When we use it continuously, about 3% of patients will develop hepatotoxicity, and when used in pulse form, 1.9% of patients are reported in literature. So that's why pulse form is safer as far as liver is concerned. If liver is damaged or your patient has high risk factors for liver damage, it's better to not use itraconazole. And if you still want to use itraconazole, the monitoring becomes faster and frequent, and you have to be more careful. Other rare side effects include neuropathy and hearing loss, hypoglycemia when itraconazole is taken with the anti-diabetic drugs, and bone and teeth abnormalities have also been mentioned in articles. That is why itraconazole is a pregnancy category C drug and not recommended to be used in childhood in children. But there have been isolated case reports using itraconazole for treatment of Tinea Capitis in younger children. But remember, it can cause bone and teeth abnormalities. So this is again a picture from Wolverton, and we are just going to revise. So boxed warnings are against congestive heart failure. You cannot use it in that patients. Hepatic derangement, neurological derangement because it leads to neuropathy and hearing loss and everything. Hypersensitivity reactions, of course, it's a strict no. In cardiovascular, remember in congestive heart failure, you have to be very careful, and it can also cause decreased neutrophils, neutropenia. Remember, additional use, non-fungal use, we learnt that itraconazole leads to decrease in neutrophil migration, and that is how it treats palmoplantar pustulosis. So it can cause severe neutropenia. So you have to be very careful in patients who already have neutropenia. Okay. Additional thing that we can mention is that itraconazole has itraconazole has no effect on androgens. Why I am saying that? Because when we will learn about ketoconazole, you will understand it has an effect on androgens. So, itraconazole doesn't have it. Other drug reactions that have been mentioned are leukopenia, neutropenia, thrombocytopenia. You have anaphylaxis. These are all from the product insert of SPORANOX. So what I'll do is I'll just stop for 5 seconds so that you can click a screenshot if you really want to read it. Otherwise, I would suggest you to go on the internet and find the product insert and read that in detail. A lot of material is there on the adverse effects of itraconazole, so you can easily learn a lot about it. Additionally, GI disorders, hepatobiliary disorders, skin and subcutaneous tissue disorders, which includes TEN, SGS syndrome, exfoliative dermatitis, leukocytoclastic vasculitis, erythema multiforme, alopecia, photosensitivity. So these are important for us as dermatologists that these kind of side effects can happen. Other systems that may be involved are musculoskeletal or connective tissue, kidneys, urinary disorders, reproductive system. It can cause menstrual disorders and erectile dysfunction, but there is no effect on androgens per se. Now, drug interactions. Now, that is very important, okay? Because it has its inhibitory action on cytochrome enzymes, and because of the inhibitory action on cytochrome enzymes, you have a lot of drug interactions with azoles, specifically itraconazole, ketoconazole, and fluconazole. So we'll discuss about itraconazole now. With cyclosporin and tacrolimus, there can be increased drug levels leading to toxicity. So when you're using it in immunosuppressive, a patient with immunosuppressive drugs, it might increase their levels and increase side effects. Now statins can also be increased with itraconazole because cytochrome P450 mediated metabolism is there. Antipsychotic drugs like pimozide, benzodiazepine like alprazolam, triazolam, midazolam, these are all, they can be increased when taken with itraconazole. So we have to be very, very careful. All the drugs which are given bold in this table, there have been specific warnings against use of itraconazole with these drugs. And statins are one of the most common drugs that old age patient might already be on. So you have to ask a good drug history before prescribing itraconazole, or you might have increased chances of side effects with other drugs. So these are the same but lower interaction. You can see that these drugs don't have that bold character to them because there are no specific warnings. But remember, in the first slide, the previous slide, you should at least remember those bold drugs. They should be in your mind while prescribing itraconazole. You should specifically ask for usage of these kind of drugs. So in the end, we can just recapitulate that anticonvulsants decreases itraconazole. Antiarrhythmics will increase QTC interval, and QTC interval is also increased by itraconazole. Remember, negative inotropic action of itraconazole means that increased QT interval. If both drugs are increasing QT interval, your patient might land up in arrhythmias. Okay. Itraconazole can increase statins, itraconazole can increase benzodiazepine. These are the important drug interactions. And this I have taken from the product insert of SPORANOX, which categorically mentions that co-administration of cisapride, pimozide, quinidine, dofetilide, or levamethidyl with SPORANOX is contraindicated in any form of SPORANOX. SPORANOX is a trade name of itraconazole. It's a trade name of itraconazole. So that is why co-administration of these drugs are not recommended. They are contraindicated. We must ask for them. Because of itraconazole being a potent cytochrome P453A4 enzyme inhibitor, we must be very careful while giving it for fungal infection. The QT prolongation is a very serious side effect. Congestive heart failures, along with arrhythmias and ventricular dysarrhythmias, we need to be very, very careful in using patients that may have risk factors for these disorders. So we have mentioned that itraconazole is pregnancy category C. The newer category mentioned itraconazole as low risk, However, better drug would be to be used in pregnancy would be terbinafine. Okay, in pregnancy, it's category B. Itraconazole is category C. Now, itraconazole is excreted via milk, so it is not recommended in lactating mothers. It has no effect on androgens or male fertility, but since it is pregnancy category C, contraception is advised till 2 months after stopping the drug. So, you start the drug, you advise the patient for contraception, you end the drug here, and you have to give contraception for 2 months more. That's what the book mentions. Let me just turn it to black. Okay, you have to give contraception for 2 months more. So make sure that you counsel your patients for using contraception. A lot of abnormalities have been reported with itraconazole, which includes skeletal bone and teeth, which we have already mentioned before. You have skeletal, you have GU tract, genitourinary tract malformations, you have cardiovascular malformations, you even have chromosomal abnormalities with itraconazole. These all have been reported. So it's better to counsel your patient to have a certain amount of contraception, either two different types, and that should ideally extend 2 months more after stopping of the drug. Okay, let's move forward. So monitoring is easy. You have to monitor with LFT because hepatotoxicity is a very important side effects. So just look at that. If LFTs are getting deranged, you may have to decrease the dose or even stop itraconazole. And if your patient has risk factors and you still want to use itraconazole, make sure that the frequency is increased. You take a look at liver frequently. CBC is required if the treatment is more than 6 weeks because it can cause leukopenia and neutropenia. So we need to have a look out for that. And if any point of time if there's hepatic dysfunction, you may have to discontinue itraconazole. Am I clear on that? Let's move forward. Now, resistance. Resistance to itraconazole happens because of overexpression of lanosterol 14 lanosterol alpha demethylase. Okay, so I think I just felt a little bit of earthquake, so I hope it's just a little bit of earthquake. Okay, so coming back to the presentation. So resistance of itraconazole is seen by the overexpression of lanosterol alpha demethylase enzyme. The enzyme which is inhibited by itraconazole, it is expressed more, and that is how the fungal cell is able to counteract the action of itraconazole. It may also alter the binding sites, and because of the alteration of binding sites, remember very quickly I told you about the blockage of heme moiety in that enzyme. And if you alter that binding site, the itraconazole is not able to act properly. So that's another mechanism for resistance. Other is efflux pump. Efflux pumps majorly the ABC transporter protein. Now what is ABC? ABC is ATP binding cassette group of proteins. Okay, ATP binding cassette group of proteins, which are very important transporter proteins, and when they are overly expressed, they will throw the drug outside the cell wall. So here is the fungal cell, F for fungus, and we have a lot of itraconazole inside, happily blocking lanosterol alpha demethylase. But if you have overexpression of efflux pumps, which are majorly ABC group of proteins, ABC transporter proteins, these drugs are rapidly thrown out of the cell and the fungus is able to protect itself. Now, cross resistance have been mentioned majorly when the fungus is candida. So, in candidal infections, a lot of cross resistance is present. For example, if a candidal infection is resistant to itraconazole, it might be resistant to fluconazole also, or reverse is also true, because mostly I use fluconazole for candida, and itraconazole is more of a second line or second drug. But cross resistances are also there, so we have to be aware about that too. Now, this is a very important aspect to understand. Use of itraconazole with antacids. A lot of your patients, older patients, might already be taking pantoprazole or rabeprazole or something like that. and you want them to be given in a little bit of acidic environment. That's why you give it with cola, or if you give it in a fasted state, because a lot of acid secretion will start happening when you take it with food after a fasted state. So it has been found that if you use itraconazole with antacid, there is reduced plasma concentration. That is why cola beverage is advised when you are giving itraconazole in HIV positive patients who have achlorhydria. That means less gastric acid, or patients who are taking H2 receptor antagonist or other gastric acid suppressor. Why I say HIV positive? Because it has been found, the study was done in HIV positive patients, that patients who have less amount of gastric acid, there is less plasma concentration, but if you take it with 250 ml or 8 ounces of cola, the absorption is good enough. Okay, and if you if you really want to use a gastric acid suppressor, you give the gastric acid suppressor 1 hour before or 2 hours after administration of itraconazole. So if this is itraconazole, you give the gastric acid suppressor either 1 hour before, this is the, let's say, PPI, 1 hour before or 2 hours after of taking itraconazole. So the way I advise is, you take PPI first, okay, you wait for roughly about an hour, have breakfast, and then after 2 hours you can either take another PPI if you're on BD dose, or you take it with lime water. Okay, lime water in the sense, you have a glass of water, you just squeeze half a lime and then take itraconazole, and this is at the time of breakfast, early morning. So that's what I advise. Or I will switch PPI, I'll stop PPI, and I will give rabeprazole. Sorry, I'll give ranitidine, H2 inhibitors. Or what you can do is, you can give PPI, instead of giving it early morning, you can give half an hour before lunch. All we need is a good food intake half an hour to 1 hour after PPI intake, and that good food intake can easily be lunch or dinner. So you can separate itraconazole and PPI and you will be okay with it. So that's how you're supposed to give itraconazole with acid suppressors. Now coming to pellets, they have been somewhat of a hot topic, but I will not spend much time. These are important to understand if you want to understand the basics of itraconazole absorption, and a lot of articles have been written. Go and read them. They are very interesting articles. Why we have such a huge variability in the efficacy and action of itraconazole from one brand to another. Why people prefer just one brand of itraconazole, not other brands. Why dermatologists don't want to write generic itraconazole. Why specific brands have to be mentioned, because there is a huge variability regarding the absorption spectrum, the bioavailability of itraconazole, and one of the major factors which contribute to this efficacy are the pellets. So in the start of this presentation, we mentioned that you have a certain sucrose, or it can be of other materials, so sucrose, a sphere, a little ball, and then you have itraconazole coating the sucrose, and then you have a preventive coating around it. This preventive coating is just for preservation and preventing it from getting dissolved in the stomach acid. Okay, so these are sucrose or cellulose beads coated with the drugs. Okay, and the amount of itraconazole that you transmit to the patient depends on the surface area of this individual pellet and the thickness of the coating, the thickness of the drug, the thickness of itraconazole. Okay, so we are technically not talking about surface area of individual pellet, we are talking about the total surface area of all the pellets inside a capsule. So if you open a capsule of itraconazole, if you open it, you will find multiple pellets inside. Just go and open one capsule if you have one. Multiple pellets. So if you have smaller pellets, the total surface area of all the pellets are increased. But if you have larger pellets, then what happens is the number of pellets are decreased. Also the surface area is also decreased. Okay. So remember, sphere is a geometrical sphere to have the maximum surface area with less volume, somewhat like that. I'll have to revise my topology. Okay, but remember that the amount of itraconazole that is deposited or distributed in the system depends on the thickness of coating of itraconazole over the spheres, and also the surface area of total sphere. The least size that you use, the smallest pellet that you use, higher the surface area and more the drug that can be delivered. So it has been found that more than 550 pellets for every 100 milligram of itraconazole should be there for proper drug absorption. What are the advantages of using pellets? It has less risk of dose dumping. That means a lot of drug is not released immediately. It leads to less plasma fluctuation. That means a normal or a stationary dose is maintained in the plasma, and improved drug bioavailability. So these are some of the advantages of pellets. Go and read any article, they are filled with advantages, but these are the three major advantages. Clear why itraconazole is supplied in pellet form? Why tablet forms are not that popular? So that is how we know. So SUBA-Itraconazole, I think this is the last topic in this presentation. SUBA is super bioavailable itraconazole. SU is super bioavailable itraconazole. So it doesn't use pellet system. What it uses are carrier polymers. So I told you that if you have, okay, not if you have a stomach. So here is stomach and here the intestine. Itraconazole is absorbed inside the intestine. It has to be released at the intestinal level for proper absorption. If we use a pellet which is coated by a protective layer, it helps itraconazole to reach intestine without destruction and leads to good absorption. That is why we use pellets. What happens in SUBA-Itraconazole is these are carrier polymers which have incorporated inside them the molecule of itraconazole. And these carrier molecules will dissolve only when they come in contact with high pH. And in stomach we have acid, that means low pH. So the SUBA-Itraconazole is spared the destruction by stomach acid. It reaches the intestine, and in the intestinal level of high pH it dissolves, leading to release of itraconazole in intestine. And when it is released, it is absorbed. So because of that, you have more bioavailability with SUBA. That is why super bioavailable. You have good amount of drug deposited in the intestine, leading to good absorption of itraconazole. That is why SUBA is touted to be better than normal itraconazole. The bioavailability increases 90%. Remember that for normal itraconazole, it is around about 55%. That means near double the amount of bioavailability. That is why in some of the articles we will mention bioavailability of itraconazole is 180% when compared to normal itraconazole. Okay, so bioavailability is nearly double. It leads to high serum levels and no effect of food or antacids. That is the one of the good advantages of SUBA-Itraconazole. Okay. But always remember one thing. It has been approved for deep fungal infections only. It is not to be used in dermatophyte till proper studies happen, till it has an approval. There have been a lot of marketing campaign regarding the use of SUBA-Itraconazole in the treatment of dermatophyte infection, but remember it is not approved yet. So if you want to use it, don't use it. Okay, you have to be very careful by using SUBA. SUBA is a good drug, but I think we should look at all the other parameters like side effect profile of increased itraconazole or any other side effects which are different from regular itraconazole. Just for your information, it is not recommended to be used in tinea as of now. It might get approval later on, we don't know. So since because itraconazole, the SUBA-Itraconazole has more bioavailability, even 65 milligram of SUBA is equal to 100 milligram of conventional itraconazole or normal itraconazole, and 135 milligram of SUBA is equal to 200 milligram of conventional itraconazole. These dosages you must remember. They are easily asked in vivas and exam. So for SUBA you use lower dose because a lot is absorbed in intestine. And approval to be used in systemic mycosis, deep mycosis, is actually received by only 65 and 135. Higher doses might be available. I think I have heard of 400 milligram itraconazole once, but I have not seen it. You have to be very, very careful while using antifungal drugs because of rising resistances. Clear? So with that, we have finished this presentation. It was a long presentation, briefly punctuated by a scare of earthquake, I think, and I think it is just me recording this video without having my dinner. So that is till I have confirmation from news channels. I don't know there was an earthquake or not. Okay. So for further reading, I would recommend you read the product insert, the product drug insert for SPORANOX, or you read it for any itraconazole for that matter. Two articles that I mentioned was Efficacy of oral itraconazole in the treatment of and relapse prevention of moderate to severe seborrheic dermatitis, in which we discuss the use of itraconazole in seborrheic dermatitis. It's a good article. If you want and if you're interested, you should go ahead and read the full text. Other is Itraconazole in the treatment of non-fungal cutaneous disease, a review. It is a good article mentioning all the other uses of itraconazole which are not acting on fungal mechanisms, other mechanisms of action like blockage of a hedgehog protein system. Okay, itraconazole attaches to the smoothened receptor in the hedgehog system, thereby decreasing basal cell carcinoma. Good articles. Go through it. These are good articles to read. So with that, we have finished the presentation of itraconazole. I hope this video was helpful. You were able to learn a bit about itraconazole. Go through this video again and again, and trust me, all the characteristics of itraconazole will be cemented in your mind, and you'll be able to use it properly. We as dermatologists have to be very, very particular while using antifungal drugs. We cannot push resistances for dermatophyte infection. We'll land up in big trouble. If we want to use itraconazole judiciously and properly, we must know everything about it. I will not speak much in the last slide because it has already been greater than 1 hour of me speaking, and it is a longer presentation. So I'll stop here right here. Any comments, you can easily email me on my email ID, or you can just mention it in the comment section. Any suggestions how to make this PPTs, make these lectures much more worthwhile. Otherwise, I'll finish it here. Adios, be safe. Okay, adios amigos, bye bye. And just a passing or a parting remark regarding what is happening in Middle East. I hope better sense prevails. I hope people are able to understand that every conflict is actually useless, and in the grand scheme of things, nobody is a winner. Okay, so with this solemn message, I'll stop this presentation. Bye bye, and let's pray for all the casualties.